So in our study, we had a team of medical students who called over 300 practices across 4 geographic regions. And the medical students and myself posed as members of a medical team trying to help set up an appointment for a patient weighing just over 450 pounds. And then we asked a series of questions to see whether the doctor's office would, first of all, schedule the visit with the patient. And then we asked if they had an exam table or an exam chair that would accommodate the patient. Shockingly, we found that 40% of medical subspecialty practices that we sampled just flat out would not schedule a visit with the hypothetical patient.
Hello, everyone, and welcome to Fresh Perspectives. I'm James Zervios, Vice President and Chief Operating Officer of the Obesity Action Coalition, and I'll be moderating today's episode. Today's conversation is called Everybody Deserves Care, and we'll be talking about access, dignity, and the patient experience. We'll look at how healthcare environments, systems, and attitudes can either make people feel supported or create barriers that keep them from getting the care they deserve. I am joined today by a panel that brings a mix of research, clinical expertise, and lived experience to this discussion. Let me introduce our panelists. We're joined by Dr. Molly Hales, a physician and researcher, who recently published a study examining barriers to subspecialty care and how healthcare systems can limit access for people living with obesity. Next up, Dr. Angela Fitch, co-founder of Knownwell Health and OAC board member, who brings a clinical and health system perspective on what inclusive, patient-centered care can look like in practice. Patty Nece, past OAC Board Chair and longtime patient advocate, who brings both lived experience and a strong advocacy lens to this conversation. And last but not least, Sarah Bramblette, OAC Senior Advocacy Manager, who will share professional insight along with her own personal experiences navigating barriers in healthcare. Thank you all so much for being here.
It's a pleasure.
Thanks for having us.
Thank you for having us.
Thank you.
Molly, I'd love to start with you. Can you tell us about the study you conducted, what motivated it, how you approached the research, and what you learned about access to subspecialty care and the patient experience?
Of course. So in our study, we had a team of medical students who called over 300 practices across 4 geographic regions, the East Coast, the West Coast, the Midwest, and the South, and 5 different medical specialties, including a mix of more medical specialties and more surgical specialties. And the medical students and myself posed as members of a medical team trying to help set up an appointment for a patient weighing just over 450 pounds. And then we asked a series of questions to see whether the doctor's office would, first of all, schedule the visit with the patient. And then if they said that they were willing to schedule, we asked if they had an exam table or an exam chair that would accommodate the patient, and then a series of other sort of basic medical equipment that you would need to be able to safely and sensitively care for a patient at that weight. And shockingly, we found that 40% of medical subspecialty practices that we sampled just flat out would not schedule a visit with the hypothetical patient. And actually, over half of the medical practices were not equipped to be able to provide care in all aspects of the visit, either having some piece of equipment that they lacked or having some kind of workaround that we thought would place undue stress on the hypothetical patient who needed to see the physician. And this was despite the fact that we were telling these medical practices that the patient needed to be seen for conditions that in many cases were meant to alert staff to the potential for a very serious condition that needed immediate care. So for example, when we called ENT offices, ear, nose, and throat doctors, we said that the patient had new hoarseness and a mass seen on imaging. So those findings together, if you have any kind of medical background, are very concerning for a new cancer that needs to be urgently worked up. And yet, unfortunately, ENTs in particular, fewer than half of practices would schedule that hypothetical patient. So really shocking results. We also found that it was actually really difficult to get that information. Most of the medical staff members were not trained, were not able to tell our hypothetical medical staff members whether or not they even had the equipment that we were asking about. And there were many potentially quite stigmatizing comments that we received, even just calling on the patient's behalf.
Thank you, Molly. I think we're going to dig into that a lot. And I think it's something that here at OAC for over 20 years we've seen time and time again. And maybe my next question I'll direct to Angela. Building on that from your experience in clinical practice, how do physical spaces and equipment impact what a patient might be experiencing in a clinical setting?
Thanks, James. Yes, it's so very important, as you know. And as Molly mentioned, this has been going on for quite some time, despite the fact that over 40% of the US population has the disease of obesity. And so if you think about it, I mean, one time I was, we were redesigning a general medicine space or general specialty space in a new building. And we happened to have our weight center in that same building. And we were talking about, making sure we had size inclusive furniture. And the fact that I had to advocate for that at all, meaning we should just have that anyway, because I was saying that 40% of patients have the issue with obesity. And so why would we not just plan for that in our just routine, planning of the space? And so I think, really making sure that we get past that stigma and we can actually, help all of our care team, including our buildings and people that are, architecture, people that are doing the planning for us, that this is a problem for our patients that we shouldn't be ignoring.
Yeah, Angela, I mean, again, similar to Molly, you bring up some very valid points. And I think things that we would maybe society just assumes are there for people living with the disease of obesity, but we know that they're not. And, great segue to you, Patty, is you've dealt with this issue a lot. We've talked about this. You've led our weight bias efforts for many years here at OAC. What are some of the things as a patient that you've experienced in these settings that will kind of speak to what we've heard so far?
Some of it is exactly what Dr. Fitch is talking about. It's just the physical setting. Inadequate waiting room chairs, inadequately sized blood pressure cuffs, exam tables that won't support higher weights, even scales that don't go to higher weights, and scales in public. All of that, when you don't have adequate facilities and adequate equipment. Oh, and let me also mention gowns. How hard is it to have large size gowns? I mean, it's a piece of material, but when you don't have these things, it is humiliating for a patient, and it breaks down their trust, not just with that individual medical professional or that office or that practice, but across the medical sphere. It makes you not want to ever go back, even when you're sick, because it's such a humiliating and shaming experience. I recently, as you said, James, I've advocated in this field for years. Well, I recently did something to the inside of one of my legs. I could barely walk. I was in tremendous pain. And despite all my advocacy work, even I was refusing to go to a doctor. I knew I needed to see an orthopedist. I've had really bad experiences with orthopedists in the past, including one who diagnosed me with obesity pain instead of severe scoliosis, which was my real diagnosis, because he wouldn't look past my weight. But it took people talking me into going to find out what was wrong with my leg. And I had torn an adductor, which is an important thing. But I waited for a month at least in great pain to go and see what was going on. And once I got a diagnosis, I could do some therapy and things like that to help alleviate the pain. Some of it, frankly, with that, I just had to wait out time wise. But all of this has like a domino effect, or where when you're just not comfortable and you start to not trust. And it's so important in medical spaces to have trust. in the professionals you're seeing.
Yeah, Patty, a great point. And we've talked about this. I mean, I think you and I have even had this discussion personally for many years, just working with you here at OAC, that if there's one place people should feel most comfortable to be vulnerable or talk about their health, it would be in a healthcare setting.
That's right.
And yet, we've seen time and time and time again, for all the reasons you talked about, gowns, blood pressure cuffs, the scale you're using to weigh someone, where you're using to, where the person is being weighed, people first language. These are all things that I would say they're not big lifts. I mean, I think Angela just spoke about this a moment ago. These are not big lifts for healthcare providers to do, yet, as you just said, we still see this day in and day out.
That's right. And it just seems those are very basic. Of course, there are many other things healthcare providers need to do, like identifying their own biases, like that orthopedist I saw who diagnosed me with obesity pain, which isn't a diagnosis. They have to identify their own biases and then work against them. Try and leave judgment at the exam room door. Most of us with obesity have tried everything we can do to manage our weight. And to then basically accuse us of not doing that it's sort of heartbreaking that medical professionals don't acknowledge that oftentimes. They leap to conclusions instead of being curious.
Thank you, Patty. And Sarah, now to you, and as Patty and I have been talking about this, and you've heard from Molly and Angela, I'm sure you've been thinking about this. You've navigated both physical and system level barriers in healthcare. What stands out most from your experiences that you just wish clinicians understood and would do better?
I think what stands out the most is Angela mentioned, we make up 40% of the population, and yet we're not accounted for even in some of the most basic ways. And we're also blamed often for being a burden on the healthcare system, but we don't get the same level of care within the healthcare system. And so it's like, help us help ourselves. Oftentimes it's assumed that we're not trying or we don't want to take care of ourselves. Well, how am I supposed to, get my recommended screenings if there's not an MRI machine for me to do that, or if I'm not comfortable going for that screening because there's not a gown that's going to fit me or a chair for me to sit in. And so that's like the overall. And then as I dug into it, as you mentioned, like the policy side of things, I always want to say, like, why isn't this? Like, we have the ADA, the Americans with Disabilities Act, and, not everyone with obesity is a disability, but it is a medical condition. And for some people it is. It is for myself. Personally, I'm on disability because of the diagnosis of obesity along with other medical conditions. And so what's surprising is the ADA requirements for buildings doesn't even accommodate bariatric size, like wheelchairs or bariatric size chair equipment. And so, I personally have seen friends who have a bariatric wheelchair who can't see a doctor because the doctor's office door isn't wide enough to get their wheelchair through. And then on that side, even bariatric equipment, I found out, has an average weight of 350 pounds. And I'm above that. So even when I was trying to access care and I was over a capacity limit, it's just very frustrating because even the policies and the guidelines aren't built for us. And I'm also of a belief that there shouldn't be a policy existing for you to take care of a patient. Facilities and doctors should want to help us, but that certainly is a barrier. And even when a doctor might want to help you, if they can't find somewhere for you to get a test done or to have a procedure done, their hands feel tied. It is ultimately, and I think this is that aspect of the subspecialty care is, when you need those other diagnostic tests done to evaluate a condition, or also the arbitrary BMI restrictions for surgeries. Like, I understand being cleared medically for surgery, but when there's just a BMI cutoff of, no, you can't have knee replacement, BMI of 35, or we don't do reconstructive surgery because you need to get under a certain limit. And maybe someone who's lost a large amount of weight and has a lot of excess skin can't move well enough. Someone who needs a new knee can't move well enough to continue to lose weight. And so there's just a lot of barriers to all care at every level that needs corrected.
Thank you very much, Sarah. I'd like to open this up to the group for a moment. Where do you all see the biggest opportunity for meaningful change when it comes to access and the patient experience? And maybe Molly, we'll start with you.
Well, I think the main reason that the medical practices cited for not being willing or able to accommodate the patient was that they didn't have either an exam table or an exam chair that could hold or accommodate the higher weight patient. So I think on the most basic and most fundamental level, really every medical practice should have a bariatric exam table. I think smaller practices maybe cite concerns over expense or space, but bariatric exams tables are available for really the cost of an ordinary exam table if providers and staff members are motivated and willing to actually seek that out. So I think really that is just the first thing that needs to be done to make sure that patients can be safely seen.
Thank you very much. And I'll go to Patty next.
As we've talked, covering the basics is very important. And I totally agree with Molly that, there should be appropriate equipment, even when it's larger scale equipment, like exam tables and whatnot. And I've seen it. Some medical institutions are very good at doing it. And as they're replacing things, they upgrade. And they do provide appropriate accommodations for people of size. To call out one, for example, I've seen it at Georgetown Hospital, both in their seating and in their exam tables. They really are trying to accommodate all sorts of patients. And that's what it's about. And it's not like an exam table. If it's a bariatric exam table, they can use it for anybody it's not like it has to sit there and wait for that 425-pound patient to walk in the room. It can be used by any of us sitting here, kind of thing. So I think that's, as things are replaced, I don't see any excuse for not upgrading, at least in those circumstances, so that you can treat the 40% of Americans that live their lives in larger bodies.
I agree with you very, very much, Patty. I don't think that we're asking a lot there. Excellent points. Angela?
Well, I was really, happy that Dr. Hales and her team, published this study or did the study and published it, because I think it opens up a huge opportunity, as she mentioned, for training, right? Training not only, I think a lot of us, in the healthcare space may have this training, and a lot of the doctors that potentially Dr. Hales' team called on would be fine seeing the patient and would say yes, but again, maybe the staff isn't trained that they have that equipment even, or maybe the staff doesn't even know that the tables, are adequate and go up that high. So I think, really training all of the care team members, as I mentioned, even the architects, the people designing the space, because again, it should be, as Patty and Molly both mentioned, it should just be standard of care to have these things in the office. We have exam tables that even weigh the patient. So if a patient is in a wheelchair, whether they're living in a larger body or not, even, they can potentially transfer over to the table and sit there and get their weight on the table, so they don't have to, be on a wheelchair scale, which takes up a lot of space. And so again, there's a lot of different ways with some of the technology, as Molly mentioned, that's not that much more expensive than what the sort of standard, type of equipment we have. We just have to get past that weight bias and stigma, I think, is what's holding us back, because, educating the entire team and really the world, right, that this is a problem, so that we can make sure that it doesn't continue to be a problem moving forward.
Thank you very much. Last but not least, Sarah, I'll leave it to you for some closing thoughts on this.
So my closing thoughts are, I want to encourage patients to speak up for what you need. I've recently heard from a fellow patient advocate that they went to an urgent care and there wasn't seating available in the waiting room. And they just filled out the survey. I think most people know now we get surveys after most medical appointments, how was your care? And so they, mentioned the seating, and they were shocked that the manager of the urgent care contacted them. And it was just a fact that they didn't realize it. If you think about it, many times the staff aren't in the waiting room. They enter through a back entrance. They're in the exam area all the time. They don't see what's happening in the waiting room, and they don't maybe realize how small or how uncomfortable the chairs may be. And, there is some positive, as you've mentioned, James, and as Patty mentioned, we've been advocating for better access to care over the years. And in 2024, there was a opportunity through the Health and Human Services Centers for Civil Rights to actually submit complaints against healthcare facilities that don't accommodate your needs. It is based on disability, but they stated in a final rule that OAC did contribute comments on to point out the need for obesity care. So they did state that in certain circumstances, obesity could be a disability for patients and that they need to be accommodated to ensure that they get the care that they need. So there is a system to do that. It can be as simple as a survey after your visit, or if you're not getting the care you need, even after you've communicated with the facility, there's a way to escalate that higher to get the care we need and the care that we should demand that we receive. Obesity is a disease, and as we always said, it needs to be treated the same as every other chronic condition.
Thank you all again so much for sharing your time, insight, and perspective today. For those of you watching, if you found this information helpful, please hit the like button and be sure to subscribe to the OAC's YouTube channel for more content like this. Thank you for tuning in.